It's Dr. Tofi. Welcome to HerniaTalk Live. I'm your host, Dr. Shirin Tofi. I'm your hernia and laparoscopic surgery specialist. Thanks to everyone who's joining me on Twitter and Instagram at HerniaTalk. Many of you are here live as a Facebook Live at Dr. Tofi, or you're here with the Zoom link. I'm super excited about today. We've been planning to have our guest for the past year. His name is Martin O'Neill. He comes to me from Europe, which is why we're doing this kind of as earlier time than usual. He is a patient advocate and mesh injured, and he's got a great story. You can follow him on Twitter at O'Neillmar, Oneillmar. I follow him. He follows me. It's been great. Welcome, Martin. I'm so happy to have you.
Hi, Dr. Tofi. Thank you for having me.
So
Exciting.
We've interacted on social media before.
Yes.
But I had the pleasure of meeting you almost exactly a year ago.
Yes. Strangely enough, yes, in Manchester.
Yeah.
It was a wonderful time.
I was so
wonderful time.
privileged to it was a great opportunity. I'm glad that you were able to make the time because you don't so for those of you listening, the European Hernia Society meeting last year was held in Manchester, and it was hosted by the British Hernia Society. So I flew to London and then Manchester. It was my first time in the UK, and I fell completely in love with it. Can I tell you that? So much so I want to go back, and you know a little bit about my story about that. And I reached out to some people that I knew and said, hey, I'm going to be in town. It would be great if I could meet you. And Martin's like, I'll be there. So maybe you can explain, because you don't live in Manchester. You had to fly in.
No. Yes. I live in an island called Jersey, which is 14 miles off the coast of France. We are our own island. There is a bailiwick. There's about 5 or 6 other islands around it. And when you asked to come, I was like, amazing, I'm off. Because I was in a very fortunate position that I've met wonderful surgeons like you, Dr. Mushawek, and beyond. And I've gathered quite a lot of information and friends along the way. So meeting you was amazing because prior to mesh removal, I sat and watched HerniaTalk Live many nights, many times, and the hope that, I think most of us whom were mesh damaged are all hoping that we get to Dr. Tofi because you are the most prominent surgeon who speaks out openly around what's happening in the mesh.
Yeah. You have a great story. I really want to delve deep into it. So you flew in to?
I flew into Manchester, directly to Manchester.
Yeah, just for that one day, right? Or did you stay for the?
I stayed for 2 days in the end, but it was just the 2 days. But the first day to meet you, the second day, a couple of hours then go.
Yeah.
But it was I couldn't
you're
have
Scottish,
paid.
Right?
Yes, I'm Scottish. So my father moved here when I was 4. I moved here just before I was 20. So unfortunately, Jersey now has a Channel Highlander and myself. So it's been a wonderful journey living here within Jersey. And particularly the last sort of 10 years, I've found both sides of Jersey. I found the horror of it, obviously the lack of medical, what we need here, what we actually physically need on island, and equally the benefit from everyone. The people here in Jersey are something else. They're wonderful, wonderful people.
Well, I may come visit you. I'm coming back for the European Hernia Society meeting next year, which is in Prague, but I plan to do a little stop in London as a follow-up to what we were discussing earlier.
I would love you to come to Jersey and hopefully meet some of our team here within the surgical community. That would be wonderful.
I'll definitely I'll definitely put that on my list.
Yes.
Yeah, absolutely. I love I personally love the international aspect of hernia surgery. I don't know that any of the other specialties have such a robust family of surgeons that internationally we all know each other, we hang out with each other, we travel together. I love learning and seeing new cultures as part of the surgical experience. I don't know. I love that. So yeah, it'll definitely be on the list for sure.
So,
Now
sorry,
that
I've lost connection here, so I missed half of what you said. So my apologies. I didn't hear anything of what you said there.
Oh, can you hear me? Can you hear me now? Can you hear me? Let's see. Can you hear me now? There we go. Now you can hear me. Can you hear me now?
Hello.
Now you can hear me, yes?
Yes, I can hear you now. I've got you back now.
It's the damn computer. Okay. Oh, see, now that I have a link, someone there, I will definitely add you to my list of places to visit. And I always joke, people go to see museums and stuff. I go and see, when I go to different countries, I go and see like hospitals,
Yeah.
operating rooms. That's
Yeah.
like my museums. But
Well, I'm pretty sure our surgeons would love to have you over
yeah,
here to speak with
yeah.
in all manner
Happy
of
to teach them
capacities.
or
Yeah,
yeah.
that would be wonderful.
For sure. Okay, so I would like to hear your story. I kind of know your story a little bit, but maybe we can start with you sharing, like, why did you even have a hernia surgery?
I had it because I was told that I needed it.
Mm-hmm.
I was told that it was needed. I was told it was a gold standard. They would
Did you
insert a
have
little mesh.
groin pain or a bulge or
I
what was
had a
this?
groin pain, didn't have any bulge, didn't have anything. It was
Okay.
found by accident, coincidentally.
Uh-huh.
I had lifted something at work and I damaged the groin.
What kind of work were you doing
I worked on the docks here at the harbour, so
on the docks? Yeah.
I lifted a heavy box, you see,
Yeah.
and that's where it started from.
And did you have pain just in the groin or did it radiate to your inner thigh, your lower back,
Just
into
on
the
the groin,
ankle?
just on the
Just
groin.
in the groin.
Yeah.
And they said you have a hernia or you might have a hernia. Like, how was that diagnosed?
6 weeks after the initial injury, I went back to the GP, the doctor,
Mm-hmm.
3 times within the 6 weeks. And that's after the 6 weeks, that's when we had a scan and we found the hernia. So the
Got
pain
it.
I had was then blamed upon the hernia.
Was
Yeah.
that a ultrasound or CAT scan?
Ultrasound,
Ultrasound found the
ultrasound,
hernia.
yeah.
So one thing I'll comment is, there are plenty of people out in the world that have hernias. It's one of the more common diagnoses, but what's really key is to make sure the hernia is the cause of the pain, right? So I see a lot of patients that have hernias, but it's not the cause of their pain.
Mm.
But it's an obvious thing, right? They go examine, like, I kind of have pain here, like, oh, there's this bulging hernia, it must be it. And then they have surgery. And it didn't, and it was probably not from that. It was like they had a hip disorder, let's say, or they had back problems. And so what ends up happening is the original cause of the pain is not addressed, but then now they have a complication from the hernia repair. And so now they have two problems that they have to deal with, whereas before there was one. So I'll tell you, we have something coming up, hopefully by the end of this year. We call it the hernia score. So
Yeah.
this is free. You can go on our website. It's not ready yet, but by December, hopefully it will be. You plug in all your symptoms and it'll spit out a score as to the likelihood that those symptoms are due to a hernia, as opposed to like I said, like a hip disorder or maybe an
Yes.
ovarian cyst in women or something like that, where, yeah, you have a hernia, but does fixing the hernia is that going to address your pain? And depending on those symptoms, it's a very, very valid and highly reliable scoring system that we're going to launch in about a month.
Good, because it's much needed. It's much needed, I believe.
Yeah, and it can help, like, you as a patient can go
Mm.
online and do it, or maybe a doctor doesn't know if
Equally, yes.
like, why, scratching their head, why is this patient having pain? I don't know. Then they put the score in, like, oh, it's because of a hernia. So it can help people who have obvious hernias be guided as to whether a hernia repair will fix their symptoms. But it also reversely will help people that don't have an obvious hernia put hernia into their diagnosis instead of being told, oh, it's on your head. It's mostly women, a lot of your head, or
Yeah, yeah.
there's it's maybe
I've
your
heard all
ovaries,
of this.
or it's your
Yeah.
appendix. Yeah.
It's the difficulty is upon this pain side of things, equally post-op after the hernia is repaired.
Yeah.
This is what I found. I've been blessed to speak to over 250 men globally now.
Wow.
So most of these men will not speak in public. 99% of them, in fact, will not speak. In fact, that's pretty much the way it is for most men. They just be quiet, they take it on the chin, and they kind of sorry, my phone just went out. And they kind of just get on with it. Now, post-op pain, when we wake up and we're in a lot of pain, most men say that immediately when they've woke up, they're in so much pain, but nothing happens because it's classed as post-op pain. So this is where the points come around of, this is early on, yes, immediately after surgery. This is where we should be, right, there should be a type of process involved in here, which could help diagnose either a complication from where the mesh has been situated, something around that. Because that's what men seem to come across with, is immediately when they wake up, that's when they find that they're worse than what they were before, which is not the way to be.
Yeah. So, and that's one of your passions, which you first told me, is that, the women have done a good job eventually kind of getting information out there about the pelvic mesh, the transvaginal mesh, and therefore that proactiveness on the women's part has been able to kind of trickle over to the mesh, the hernia mesh world, right? But I agree with you. Most people who have problems with hernia mesh are men, not women, because they're just more men having hernia surgery than women. I think statistically, if you look at chronic pain, more women have chronic pain percentage-wise, more chronic pain risk than men with hernia repairs. However, a dramatically higher number of men, something like 5 to 7x of men, have hernias repaired than women. So, like, pure numbers basis, more men are affected. And what you're saying is very valid, which is perhaps men being men don't complain as much, at least not publicly. And then when they go see their doctor, they're told to just suck it up and be a man about it. And you just had surgery, stop being a kid.
That's what I was told immediately. I woke up and I was told there was 4 other men who had the surgery. Stop being a baby, I will say this. When I left the hospital, my girlfriend at the time, who is no fool, she doesn't suffer pain, etc. And she was just astonished that was even allowed to go home. But I was basically kicked out and told there's nothing wrong with it, it's post-op. So that has to filter down equally from surgeons down into the team who are the nurses on the ground, you see.
Yeah, and you have people that are watching right now that are saying, one's from South Africa, saying that men in her country or in his country are very silent about mesh complications, and that's probably true.
It's everywhere, Dr. Tofi. I've spoken to men from America, from shall we say, Eastern Bloc communities or countries.
Yeah.
It's everywhere, everywhere. I've spoken to 70-year-old men whom have not told their wife.
Yes.
You know,
yes.
it's
The same story. Yeah.
yeah, it's horrid. It's horrid.
Yeah.
You know, and to
Tell
think
me.
that the beauty within it is that women have paved the way, and they've done it coincidentally, sorry, through a different avenue. You know, it was
Yeah.
vaginal mesh that was getting spoken about mostly,
Yeah.
but then the everyone else sort of piled in. But what we need is more men within this space, because they are there. They are there,
Yeah.
even if it's privately. There are other men like me, etc., whom would speak with them privately. They don't have to be involved in the groups or anything,
Yeah.
even if it's someone to talk to, in order that they can get their help and equally get what's on their chest off it.
Mm-hmm.
It's a
So,
lot.
what kind of repair did you have done?
I
Can you
had
tell me
an
the
open
technique?
Liechtenstein, so I
Open
did.
Liechtenstein. So
Yeah.
open incision in the groin, and then you
Yes.
had a flat mesh put in. No
Yes.
plug or anything like that.
No plug. No, just a flat
And
mesh.
and how were you the first, let's say, 3 days or 4 days after surgery?
And I couldn't walk. Couldn't walk.
Couldn't
Literally
walk.
couldn't walk.
And you couldn't walk because you
I
had
couldn't walk.
pain, swelling, or your like weight bearing with your
The
leg would
pain
hurt.
was ferocious.
Uh-huh.
Every step I took, the pain within the groin. Just imagine if you hit a sore tooth with a hammer at the dentist. Every step I get that, even now to this day.
Oh.
So it's painful. It's extremely painful.
And did you get very bruised?
Yes, yeah, very
Okay.
bruised.
You know, bruising is a part of any surgery, but sometimes I gauge either how big the hernia was or how complicated the surgery was, or sometimes how heavy-handed the surgeon was based on how much bruising people get post-op. Yeah, it happens, but if you see someone complicated and with pain, and then you think back and they're like, oh, I was so bruised, like my entire scrotum was purple and my penile shaft was purple and my whole like upper thigh was purple, then, you know, sometimes you wonder if it was more of a surgical technique issue than just a big hernia, let's say.
That's the other complication that I was hoping to address would be the technique, and the way that it's approached, and the sheer, for want of a better word, lack of guidance around this. This is where surgeons like you are key, globally. Surgeons whom remove mesh, whom are not a general surgeon who specialised in herniorrhaphy. I absolutely believe wholeheartedly that hernia surgery should be a principal surgery, the same as a heart surgeon, etc.
That would be
Because
ideal, yeah.
yes, it would be ideal. It really would be, because it would protect the surgical community. And you don't have thousands of people like me and all the women coming in and saying this mesh, and then we're left in limbo because they don't know how to remove it.
Yeah.
And what happens then? It just becomes cost. Everything's cost. We absorb more time with different consultants, you know. So we then take more money from everyone else, and everything that's needed within the care. Multiple psychiatrists, multiple surgeons, even sometimes equally. It's a difficult thing.
Okay, so then let's go like forward maybe between 2 and 4 weeks after surgery. Did you get better a little bit?
I was able to walk, but I couldn't take stairs. I still can't take stairs. I avoid them like the plague, because it's the spasm effect and the lifting the leg up, and then weight bearing. See, weight bearing on the right leg.
Weight bearing on that foot. Yeah.
It's horrid.
And going hills and
hills is my right leg constantly wants to give way. When I put pressure onto the right leg, when it's horrible. I have to force it though, because if I didn't go walking, Dr. Tofi, I would have nothing in my life. So I have to force the walk, you see. Whereas before I loved it. I love swimming, I love cycling. I can't cycle. Can't I just
cycle.
And pubic bone pain is
was sitting more difficult back then, or was
sitting is still
standing
difficult, yeah. Yeah, I
always
constantly
difficult
fidget.
sitting,
Mm,
constantly
constant
fidgeting.
fidget.
Yeah. And did you have any pain that radiated into your inner thigh during the early stages?
No, not from the early
Okay.
stages. Later, yes, the more hindered I became when I was walking, the hip
Yeah.
pain was ferocious. Um,
Okay.
it still is bad, but on balance of everything,
Yeah.
pain is pain in a sense. We have to take it what comes,
And any testicular pain in the early stages?
Yes, yeah. Immediately on the right side, I'd testicular pain. The testicular pain then went into constant infections within the testy, swelling within the epididymis, infection within the epididymis, infection around the groin, and predominantly on the right side, where the mesh was implanted. It just became horrible. The touch of
Mhm.
to touch the testy was excruciating.
Okay.
So we elected to remove it to make things better, and
Oh,
things
you're
got a hell
kidding
of a
me. That
lot
doesn't
worse.
work.
Nah, nah.
That's not the oh my
No.
Lord. That's the wrong
Um,
decision.
but this
Sorry.
this is prior to me gaining all the knowledge which I
Yeah.
only started gaining after all of this.
Yeah.
Um, we enter into a situation where we elect to have the testis removed. I develop a massive hematomic reaction.
Yeah.
It becomes almost septic. I nearly died. We have
Oh my
3
Lord.
surgeries in the space of a week. We get through the next sort of this is in the August. We come to October, near the November time, before I'm in hospital basically for that whole period. It was like the odd few days
Yeah.
out or week out, and then I would be back in again.
So
So
a couple of comments on what I'm thinking at what happened to you at that time. So some people throw out the term Lichtenstein. Oh, you had a Lichtenstein hernia repair, and sometimes we actually read the opera report, and it's kind of like Lichtenstein like, but it's not the true Lichtenstein technique.
yeah.
Because a true Lichtenstein technique, you need to have an appropriate size mesh. Some people use too small of a mesh, so it actually becomes too tight of a repair. It's like trying to fit you into a much like 2 sizes too small of an outfit. And then the sutures, where they place the sutures is very important. You don't want to place sutures anywhere that it could damage nerves. I just took out a mesh, and they had sutures into the nerve and suture into the vessel. Like literally, I had to take suture out of a vessel. Like I just don't have enough words.
Oh,
Yeah. And then the
yeah.
other thing too is mesh. So there's different types of meshes, and there's lightweight meshes and heavyweight meshes and medium weight meshes. So the heavier weight the mesh, the more inflammatory response to it, number one. So more swelling potentially in the area. And if you're already like a heavy-handed surgeon and you're causing a lot of tissue damage and inflammation, then you slap on a heavyweight mesh, that kind of multiplies the reaction. And then also mesh shrinks. So all synthetic mesh shrinks. The lightweight mesh shrinks about 10%. And the heaviest weight meshes shrink about 25%. So the surgeon should understand that. So when they put in the mesh, it can't be placed perfectly. It's like a t-shirt, like a cotton t-shirt. If you wash it, it's going to shrink. You want to buy like one size higher, right? So the same is true for mesh. You don't want to put mesh in perfectly flat and taut, because within about 3 weeks and maximum 6 weeks, it's going to shrink. And so whereas it looked great during surgery because it looked like perfectly flat, like a fitted sheet on your mattress, by the time your body reacts to it, it's now 25% shrunken. So it's when I hear stories like I couldn't raise my leg, going upstairs is difficult, sitting is difficult. I wonder if you had too tight of a repair. And also the testicular symptoms sounds like you had a lot of I'm calling it obstruction. So it was not only too tight where it was sewn, it was also wrapped too tight around your spermatic cord, which is the blood flow to your testicle and the flow of sperm out of your testicle towards your prostate. So if it's too tight at the groin level, it's like a vise, right? Like your groin is in a vise and you can't function. You can't actively flex your hip and bring your knee to chest and go upstairs and
can't hardly do anything.
Cross your legs, for example, is another
nothing.
difficult one. Couldn't do that.
No,
Getting in and out of a chair is
day,
difficult. So that's too tight of a repair. And if it's also too tightly wrapped around the spermatic cord, and there are techniques to prevent that, the amide modification of the Lichtenstein repair, which is by Dr. Parviz Amide, who's like a mentor and great friend of mine, who fortunately lives in Los Angeles. His modification allows it so that it can never be too tight around the spermatic cord, but not everyone follows that technique because they don't know. But if you make it too tight, then the blood flow to the testicles is usually okay, but the blood flow out, the venous blood flow, is blocked. And so you get swelling and pain in the testicle. And then potentially also the spermatic flow out of the testicle can also be blocked because the mesh is eroding into the vas deferens, which is what carries the sperm. And so it's very painful to ejaculate, for example.
That's what I was having, pain on ejaculation when I was able to have sex. It was horrible. It was horrible. I remember
that's all obstruction at the intral ring. No amount of what we call orchiectomy, or taking out the testicle, helps that. And it's basically looking at like freeway traffic and seeing that there's so much traffic and not understanding there's a car crash up front that you need to address. You don't need to address the cars that are backed up. The main problem is the car crash up front.
Which would have been the mesh, coincidentally.
Which is the mesh repair.
That's it. But all this in hindsight, it can be said now, but at the time, and this is what I would like to iterate into this, is that when we're going for these surgeries, all of us around the world, when they're putting mesh inside of us, we have to ask the questions which I didn't ask because it was sold to me. It was sold to me like a car. What happens when it goes wrong? How are you implanting it? What way? What method? What mesh? What particular type? Have you removed it before? These are questions that are only prominent now because of people who have spoken up and people who are still speaking up. But this is where we have to get to. We have to get to a position where the patient is involved and we are given both scenarios. You can have a natural repair, an open shoulder repair, which may cause pain, etc. Or you can have a mesh, which could possibly all the symptoms that come with it. I was never told that.
Yeah, but also it's
placement has to come into this equally. Sorry, Dr. Tofi, I know. But placement has to come in, and this is where surgeons like your information is invaluable. Dr. Mushawek's information, etc. When a general surgeon is implanting a mesh, he should really consult before he does it an expert like yourself, who is schooled in nothing but hernias, because then we can reset nerves, we can move what doesn't belong there, we can move it out the way, and then when the mesh shrinks or it does what it does, none of that's there. You know, we've created a system where the cart is before the horse now. You know, and now we've got tens of thousands, if not hundreds of thousands of people mesh damaged, whom are screaming for people like yours help. And there's less than one.
This is the issue I have. There's plenty of surgeons that I know that when they talk, you're like, wow, he really knows what he's talking about. And then you see them operate and you're like, oh boy, I don't want them operating on me. And I learned this mostly not just through personal contact, but we did a paper that's got some good press about it, where we reviewed the top 50 YouTube videos on inguinal hernias, right?
Okay.
And if you listen to the video, they're saying exactly what you're supposed to do. You know, great. you're supposed to do this, do that, be careful here, don't hit the nerves, don't. And then if you watch the video, you're like, I was getting like palpitations and like PTSD because it was so scary watching some of these videos posted on YouTube, how crazy the operation was. So the issue that I can't resolve is, even if you query the surgeon about their technique and how they do it, how can you be assured that the average general surgeon, that their technique at your operation is going to be the right technique that doesn't hurt you?
That's why it's so imperative and fundamental that herniorrhaphy becomes a principal surgery. That is why. That's the whole. It stops the fighting. It stops the harm, which is the most dangerous part out of this. We've got men all over the world and women all over the world implanted with mesh who can't have sex, can't have children, whom can't walk. I mean, I'm lucky. I can get out some days. There are women who just can't. There are men who have got dual bilateral hernias in mesh, and I've had conversations with these men where even I have been like, this is beyond. And there's nothing that any of these surgeons were told. It comes partly from manufacturer. Equally, manufacturers should be actively explaining to surgeons when they sell this mesh, there is a possibility that this could happen. You know, we must acknowledge that nothing is perfect in the surgical realm. We must acknowledge that harm
and we
can
didn't even
happen.
know that these meshes shrink until, you know, surgeons like Dr. Amit and others like figured it out.
Yes,
here's a question.
Go for it. Yeah, sorry.
Here's a question. It says, what about cases where, in addition to the hernia defect, there is an attenuation and bulging of the inguinal floor? That's a direct inguinal hernia defect, compressing the inguinal nerve and the goal is to flatten the inguinal floor to relieve compression in addition to repairing the defect. If the mesh is too loose, will it not accomplish the goal of flattening and reinforcing, supporting the inguinal floor? So what you're talking about, this question, is about direct inguinal hernias. To do a good direct inguinal hernia repair, I just did one yesterday and another one last week, where actually this was not done. One of them that was not done. What you're supposed to do is you're supposed to take that attenuation and bulging and weakness and you tighten it, not too tight, but just enough to flatten it and not be a bulge. And then you place the mesh on top of that. And by placing the mesh on top of that, you're encouraging the mesh to now stick to your tissue repair, which was the tightening of the loose inguinal floor. But you still don't want that to be tight. You don't want tight. Tight is not good. Tight is not good when it comes to shoes. Tying it, tie is not good when you're wearing a jacket or a dress or underwear or anything. Tight is not good. So if you're wearing braces, you don't want it too tight. Like, nothing needs to be tight. It just needs to be adequate, so you don't have bulging of the intestines. And I hope that helps answer. So during your journey, sounds like one treatment that was given to you was removing your testicle, which I assume did nothing.
It made it worse. Made
it worse.
When my testicle was removed, I have to explain. Excuse me, Dr. Tofag. I was in a band whilst I was working. When I was working, I would probably be working about 90 to 100 hours a week upon average. I was a lead singer in a band also.
Wow.
So
okay, well,
all of that is gone.
A lot of abdominal pressure.
Yes.
If you have too tight of an inguinal hernia repair, you can't even talk loud, let alone sing.
The singing was brutal. It was brutal. 2017, I gave it up thinking I'll be back within 6 months, a year, you know, we'll slow down with the band, we'll come back. I can't. The beauty of it is, after Dr. Mushawek's repair, Dr. Mushawek removed my mesh, you see, in Germany. Okay. And then I had a Mushawek repair, actually Dr. Mushawek's repair system, which is wonderful. But I'm taking lessons now to actually learn how to sing, and it hurts like crazy, but I love it. I don't care. So because of the journey I've been through, now people find me walking down the street singing and they're like, is this man drunk, or has he lost his marbles? And this is my way of kind of getting back to normality, reclaiming what was taken from my life. It's a difficult process.
So she removed all of your mesh?
Yes, yeah, all of it.
And then what did she do with your nerves?
Dr. Mushawek took them out. So I'm left with just the genital, which is now giving me problems because the femoral, the femoral side of the genital femoral, the femoral is giving me issues because I'm getting shooting pains from the groin right down into the large toe and back up. So I know it's the femoral nerve.
Got it.
It's horrid. I get spasms equally within the groin, which are just you've seen them when I was in Manchester, Dr. Tofai.
Yeah, you were not sitting. Nah. So we had a handful of people I was meeting with, and everyone was sitting around, and Martin was standing, and you kind of hid yourself behind a chair, holding on to a chair, acting like everything's fine. But I did notice that you were standing because it was painful to sit. Yeah. So let me ask you this question. So Dr. Mushawek, as you know, she was a guest on HerniaTalk Live earlier this year.
I watched that with Ernest, so I did. Yeah. I really did. Yeah.
So she removed your mesh and did what's called the minimal repair.
The minimal repair.
And then she cut, sounds like, at least two nerves, the ilioinguinal, maybe the iliohypogastric.
The ilio and the genital were attached to the so I had to come out. But in essence, it did make it better. You know, I have to explain this because there's a lot of people saying, Martin, you're before I went to Dr. Mushawek, I couldn't walk. I was barely able to walk. The pain I was in was just obscene. I was taking 270 milligrams of Oxycontin a day. I was on multiple benzodiazepines. It was palliative care pain. What Dr. Mushawek found was that my mesh had fused to my pubic bone, and it had fused to the inguinal muscle ligament, the other side. So what Dr. Mushawek done, was she stopped me from deteriorating worse. That's the position. And removal of mesh is a difficult thing because even if I came to you, Dr. Tofai, we would still be in the same predicament. I believe I was in the best hands in the world with Dr. Mushawek. I've said that, and I still believe that. Dr. Mushawek,
you traveled to Germany to see her. I think she comes to London too. Yeah.
What happened was I was in talks with our government here and with the surgical fraternity, shall we say, and upon cost, it was cheaper to go to Germany. Because of all the additional stuff that the London hospitals were asking for. It was actually cheaper.
Interesting.
Really interesting, because for a lot of patients I've sent to Dr. Mushawek since, they couldn't get to Germany because of the COVID situation, you see.
Oh, the COVID situation, sure.
So we went to Germany. We arrived into Germany, myself and my auntie. My aunt came with me. We arrived there on the Sunday. On the Monday, it was lockdown. So we had 14 days mandatory lockdown, which no one knew about. Not even the hospital here, neither. Obviously, the German government did. But Dr. Mushawek's husband was fighting to still have the surgery, and it was just told no, it wasn't happening. So I had to wait 2 weeks in Germany, then another 10 days. It was a crazy journey.
So, have you had any more surgery since then?
I've not. Remember, we approached around an MRI scan that we approached privately. I'll put this publicly. I think I've reherniated. I've approached Dr. Mushawek. I wanted to go and see her. I can feel it internally. But equally, I've just moved house. The house takes all the money.
Yes,
I
yes,
have to wait, we have
yes,
to get this MRI scan done and wait for the results from that equally.
yes. So one of the thoughts behind, so if you did great with the Mushawek operation, but then kind of had like a setback, the first thing that comes to my mind is if you have a hernia recurrence. So that can happen when you remove mesh and do a tissue repair, which is completely a good option. The main risk with that is the tissue repair is not adequate because we already know even in normal tissues, the tissue repair has a higher recurrence rate.
Yeah.
And then you add to that the additional operation of having had mesh removed, which can make things complicated. So the MRI specifically with Valsalva, so with the bear down views, not a regular MRI where you're just laying flat. You got to push out to recreate the abdominal pressure you get when you're sitting and when you sit and when you bend and so on. That will help determine if you have a recurrence, and then the discussion is how to repair that. Number one, and that's very treatable. Having a recurrence as your only complication is very treatable.
It's another trip to Dr. Mushawek for another natural repair because I will not have another mesh.
You need a laparoscopic repair. You need a laparoscopic repair for that. Don't
laparoscopic, there's a lot of issues around the laparoscopic in the sense when they're inputting, when they're mesh insertion, and it comes to removing it. Removing the mesh laparoscopic, from what I've seen through groups and through the data and speaking to some surgeons, not all the mesh can come out.
100% can come out. I've never had a situation where
right. So again, it's down to skill set. Well, that's the thing. So it's down to skill set. So this is why it's imperative that you and surgeons like you teach, that you have to lead the field. We as patients have to beg for this and fight for it and ask for it around the world. That surgeons like you are invited to Scotland, Jersey, England, wherever, because your skill set is needed. It is needed. It is needed globally.
But more important than that is the skill of putting the mesh in the first place, number one. And in you, it's possible that you overly react to synthetic mesh. And so maybe a less synthetic mesh, like a hybrid mesh or something where there's less synthetic in it, would be a good option for your laparoscopic.
I wouldn't trust it. I wouldn't trust it again because of what it's done. It's not a cultist position to adopt that. It's the trust that's been destroyed in me over the 6 years of fighting. It's the being told that mesh can't do what it's done, yet it obviously has done what it's done. It's all of that. It's unfortunate because it's left a bitter taste to when, for argument's sake, when I'm 60 or 70 and I need a mesh because I have to have one. Dr. Tofai, we've spoke many times, and you've showed me instances of where mesh has to be used. Okay, I bowed down to the complete ban of it and went, okay, mesh has a place, it has a position, but not the way that every surgeon at the moment is going to. It's like a go-to thing. It's like we are losing the skill sets that you have. We are losing the skill set of the shoulders. How can you be a surgeon if you cannot do everything that you can do? Sorry, but if I was a surgeon in the hernia world, I would want to know everything about it, so as I become the best.
Surgeons don't even know how to do those shoulder dice.
And the shoulder dice is like, the shoulder dice is one of, if not the best go-to starting position.
It's part of the boards. If you take the American Board of Surgery, you have to at least conceptually understand how to do it. But if you ask any of those surgeons to actually do it, they'll say they've never done it.
I watched a wonderful YouTube video before I went to Dr. Mushawek. It was done by a husband and wife team called Sue and Peter Jones. Unfortunately, both of them have since retired. But both of these surgeons have an incredible position because both of them know the shoulder dice method. They know how to remove the mesh. I believe they were in the first predicament arguing against the use of mesh predominantly when it first came out. But equally, these surgeons were fighting for acknowledgement around the mesh and the problems that it can cause, and that as surgeons, they're losing that skill set. I mean,
Yes.
it's silly. It really is, because if you're a surgeon and you need to do an adapted natural repair, if you've not got that skill, what if the patient has autoimmune syndromes or symptoms?
Yeah.
I'm now left with autoimmune conditions around my body. So that's another reason why I can't have a mesh also.
Yeah. Yeah. Do you think you reacted to the mesh, like the actual physical particles of the mesh, or was it a surgical technique issue?
I've got fatty lipomas all over my body. All over it, Dr. Tofai. I've got skin conditions. I sweat. I can't stop sweating. I've got rashes. There's weird smells. I'm probably giving too much over, but it's just the truth.
Yeah.
It's the truth.
Do you think all of your mesh was not removed? Is there some in you?
No, I believe it was all removed.
Okay.
Absolutely, because I seen the pictures of it.
Yeah.
I know Dr. Mushawek.
She usually removes all the mesh.
Yeah. My last words to Dr. Mushawek, and it's a scary situation equally, because when we're going for mesh removal, we're equally told, if we can't do a natural repair, you may still have to have a mesh. But at least if that's the position, it's done by one of the world's best leading surgeons.
Yeah. Yeah.
So I accepted that fate and went, I'm in God's hands now.
Yeah.
This is where we go with that,
Got it. I wish we had better. We need better surgical technique.
Yes.
And we need
better guidance.
Better tools.
Better guidance.
Too.
Yes.
Yeah.
Equally, what we need is the patient. We need the patient involved. That Dr. Tofai, there is patients all over the world, you know this, whom are campaigning and are activists, and they want, we want a better surgery. We want surgeons to be better. We want our hospitals to be better. We want the techniques to be better. We also want the data collected. We want what you guys want. I believe now, as a patient advocate, that we should be using the patients to collect all this data, and within what they're harmed with, in and around the mesh, or a specific criteria that every patient advocates for. They should be involved in the process. Direct knowledge, and equally, apart from that, saying the back scenes where we could have teams of people like that collecting the data, guided by doctors, guided by healthcare assistants. And it gives us, the patient, a focus. It gives us a new lease of life, a drive, to become human again. Because that's one thing I lost, was I felt that I didn't feel, it was actually true, I wasn't part of society. I didn't work, couldn't work. I lost everything, self-respect, it all goes.
So what's out there available as a support group for specifically the men? I have a patient who is young.
At the moment, there's nothing for the men. I joined with the Scottish Global Mesh Alliance. We created this group together.
Scottish Global Mesh Alliance,
yes. We specifically made this, that we bring everyone together, because mesh has been genderified now. We've got men and women separated by mesh. We've got men and women separated by the device type, by where the mesh was implanted, and this creates, all it's doing is creating further division. And what we need is everyone together. Everyone, we need to speak, men and women. If women are so much better than men at being truthful and standing up for yourselves. Sorry, but you really are. If it wasn't for the women, I always say this, if it was not for the women, all of us, including the men, including the women with abdominal mesh, etc., if it wasn't the vaginal women standing up, none of us would have a voice. So it's so integral.
Yeah, you may be true about that. So what resources are out there for the men to share their stories?
That's if men would like to contact me through MESH.CI or Twitter or Hernia, Scottish Global Mesh Alliance, contact myself personally through Facebook. you know, the groups that we are in, they're all safe. No one speaks about it. I've had men contact me and they just call me, and they're not even involved in the groups. They just give me a call when they want to, and I speak to them and listen to them. That's
Wow.
mostly what they like,
That's a
is
lot of
just to
work.
listen.
Yeah, but as an advocate, you know, that's
part
your
of it. It's a
relationship
blessing.
is very
Yes.
powerful. Yeah.
It's a
Couple
blessing.
comments. Let me read those to you. One's telling you, so proud that you speak out, Martin, and also thanks for allowing us to have a voice and educating. Another wrote, I had left inguinal hernia surgery with mesh and a plug 8 years ago. I've had pain since day one. Why is the plug used? I have 3 more hernias, but I'm afraid of surgery. I wish I could have come surgery with you. Yeah, so the plug, I just took one out yesterday. We recommend not using the plug anymore, but it's still a very commonly used technique. It's just another technique.
But equally, so that's been recommended, and yet it's still being used. So is this a lack of speed with information getting to surgeons? Is it?
No, I'll tell you what
No.
it is. The company is afraid of removing it from the market, especially in the United States, because that will trigger lawsuits saying, "Oh, you are admitting that it's a problem." Whereas that's my impression. My impression is the company is refusing to remove that from the market because it would be admitting that there's a problem with that design, and therefore they would be held liable, and they'll just
And
help
therefore,
the lawsuits.
and what happens then is that surgeons still order it, surgeons still use it because
We're
they
gonna
don't
still
know.
use it. Yeah.
So we are in a catch-22 that equally, when we go back and say to surgeons, you guys don't know, we're looked at as if we are the plague, we're looked down upon, we are slandered, everything is then used against us as a patient.
Yeah,
It's
I
pretty
agree.
disgusting when you
Well,
go
I would
into
say
patients and surgeons.
if you talk to your surgeon and you're asking the questions you're telling them to ask,
Mm,
and they say they're going to use a plug, either ask them not to use a plug or get another surgeon. All of the guidelines now, the European Hernia Society guidelines, the International Hernia Surgery Group guidelines, all say do not use the plug. There is no reason to add the risks of a plug to a hernia repair. It doesn't add or make the hernia any better than a
no.
traditional Liechtenstein. Here's another question. My surgeon said he will use a double-breasted inguinal hernia repair. So that's a Schuldeis repair, but again, I've read opera reports where they claim they did a Schuldeis, and you read the report, they didn't do a Schuldeis. They said, oh, we did a 2-layer Schuldeis. There is no such thing. We did 3-layer Schuldeis. There is no such thing. So either
It's a show dice.
it's not a
It's just a show
Schuldeis.
dice.
Yeah.
But I've seen people saying, we're doing a laparoscopic robotic show dice. It's like, you're doing a what?
Yeah.
A show
Yeah,
dice is open.
exactly.
So it's an adapted method.
Exactly. You're
This
right.
again comes down to surgeons, the terminology, the woefulness in their head to think
Yeah.
it's fine to do that. It's not.
Yeah.
You're gaslighting the patient, and equally you're destroying good work as surgeons like you're doing.
Yeah. Another one says, I'm in the same boat as Martin. I have a recurrent hernia from a car accident a month after removal of my mesh. I don't trust the system to have it repaired. It's a problem.
I may not have a recurrence. I'm only. I
Yeah,
think.
that's true.
Yeah,
It's a theory.
we still have to. We still have to. That's so.
Yeah, only 2 surgeons in Sydney, Australia can do the shoulder ice and Maloney Darn hernia repair. I wish you were in Australia. Thank you, Martin, for sharing your story and helping others be more informed. So many are on this right now, Martin. Very nice.
I've been
Here's
very
another one.
blessed, Dr. Tofai, sorry to
Yeah.
interrupt, to meet people from all over the world. Doctors, surgeons, patient advocates. It's a blessing. It's an absolute blessing. But we struggle. We really struggle. Sorry, I'm thinking of a patient at the moment. It's hard. It's hard because I know where I was within this journey, the suicidal want. It's not an emotion, it's a want. You want to die. You do not want to live. It's a want. So when I hear patients whom are crying, etc., grown men, It's disturbing. It's
Yeah.
heartbreaking, but
Yeah.
it's a blessing. It's an absolute blessing. Mm.
Yeah. Here's another one. I'm with you, Martin. I would never have mesh again. Even when mesh is removed, you cannot undo the damage caused. And no matter how skilled the surgeon is at implanting, you cannot predict the autoimmune response. That's true.
No,
I personally met with Peter Jones, who you have mentioned, and he told me he stopped using mesh in 1990s because he did regular and thorough follow-ups with his patients, and he saw too many cases of autoimmune issues.
he's
Here's
a
another
wonderful,
comment.
wonderful man. Dr.
Jones,
Peter
yeah.
Jones, yeah, wonderful.
Yeah. Another comment. I also have a hernia and I'm not trusting my doctors ever again. They ruined my life with putting this mesh. Now I'm needing a hernia repair. Another comment. The sad fact is that the governments appear to care. They commend our advocacy and they note our requests, but the ministers are going on what their advisors tell them, not us. Apparently, native tissue repairs are nowhere in the literature. That's so not true. It's all over the literature.
Well, this is the difficulty. We've got civil servants directing private healthcare once within a public realm, which have adverse reactions. It's a different healthcare system, you see. So we need government to listen to us all over the world, not just in Scotland, England, etc. We need them all over the world because us as patients, we're not crying about this because it's a willy-nilly feeling. It is something that it's unnatural. That is the only way to explain this. I've had broken ribs. I've had all sorts of different pain, but this pain is unnatural. It is something that does not stop. Yeah. It's incessant.
And governments, suicide or feeling suicidal is definitely part of this.
Dr. Trophy, I tried 6 times. I tried 6 times. I wanted to die. A clear want. God has kept me here for something. Yeah. And I believe that that something is to open the voice up and to bring us all together. I'm not saying this that I'm the person to do it. There is lots of people who are doing this. I'm just one amongst many. But we need government to listen and to pay attention to the people and not the people whom are harmed and not the people whom are pushing contracts that involve millions of pounds. This is the difference. Yeah. It's a clear and definite cry for help that everyone in government goes, don't want. It's sad.
Oh boy. Here's another one. Let me go to these comments. In my country, our parliament members lied and said they removed the mesh from the market. When I did the investigation, I found out until today it's used among patients. Here's another comment. Yes, my surgeon said his double-breasted repair Schuldeis is the 2-layer repair. I'm glad I came on here and now I'm worried. Yeah, Schuldeis is not 2 layers. Schuldeis is 4 layers.
It's
I can't handle this.
You see the terminology within this and how the patients are getting gaslighted, Dr. Tofa. You see, this is why herniophory is so important that it becomes a principled surgery. And to be honest with you, I've been working around costs. So when a mesh injured patient is there and prevalent, the IQR, the interquarterly rate, expands by 5 times the volume. So, you know, I cost my government in 2020 with admissions, etc., just admissions over £100,000 in 1 year. So we have to face,
for sure,
we have to face cost as well.
Weren't you in the intensive care unit for a while?
19 times I've been admitted.
19 times for pain
control. To control the spasm
and spasms.
And spasm. Yeah, it's the pain is unbelievable. I'm better now. The pain is better now, but it's the spasm. The spasm is horrendous. It's the worst thing that came around all the surgeries after 2017. The spasms became.
I can see you fidgeted throughout this hour, and you look like you want to stand up.
No, I'm fine. Honestly, I'm fine. I had a little walk before, just to clear the head. I had a little walk, so yeah.
The hour went by very quickly,
We need to
Martin.
do another one.
Some more. We should do another one.
I would love to do another one with other patients and other surgeons. But
Yeah.
this is the thing I love about speaking with you, Dr. Tofai, because
Yeah.
I can be harsh and say the truth, but it's respectful. I'll
Yeah.
always say it respectfully, and equally back from you, it's been the same. But I think we started speaking in 2019 on and off,
Yeah.
through HerniaTalk, etc. And
Yeah.
and that's the thing where we've built bridges, and I think if we can do this around the world, everything, and every service of healthcare, it does nothing apart from get better. It just gets better when we speak about it, when we open it out and look for the bad, actively look for it, not in a derogatory way to blame anyone. It's to say we need to make it better. That's all it is.
I agree with you. And I do feel in the past decade where I've been doing this, where I've included patient like advocacy and kind of discussion forums, I do feel that the sentiment has improved a little bit on both sides. I feel the surgeons are now less afraid of patients and more likely to include patients in their research studies and their meetings and their societies and have the patient voice. And I feel that patients are less likely to just say, you're an evil doctor, and more likely to listen a little bit and give a little bit more respect to doctors who are hoping
Yes.
to
And it's needed from both sides. Yeah. We need to understand your position. You have legal positions as surgeons, and it's different all over the world. And not to mention the position and duty of care that you adopt as a normal person towards a patient. And there's all of that to consider. Equally, costs, directions from the bosses, everything has to come into play. But if the patient's involved and we're all talking and the communication's free-flowing, positive free-flowing information will always make things better, in my view.
This is true. I'm glad we're moving in the right direction, at least. And if we can just improve the products that are out there as well with industry, which I think we're slowly doing, will go a long way.
I believe you have been an integral part to me becoming what I've become, but equally around the world, a lot of patients listen to you. They admire you. They admire that you're honest around it, as honest as you can be, because obviously there's the surgical fraternity who may, have words against what you're saying, but it's the truth. There's nothing. The truth is the truth. And you have opened it up and shone a light inside, and a lot of people do love and respect, and they're absolutely grateful for what you do. I am one of these people. And we have others uncelebrated heroes like Dr. Mushawek, whom just grace life and go forward and don't hear anything, of the good that they've done, you see. So keep going, Dr. Tofai, and I think the patients will stick behind you.
Thank you very much. Thank you for your time. I know it's evening there already, and I appreciate you agreeing to come on HerniaTalk and share your story. And I do hope that this becomes one of our more popular episodes. You can follow it and watch it on YouTube. It'll be there in about a day at HerniaTalk. I have a podcast now, so it'll soon be on my podcast.
Yeah,
it's already on Facebook Live and we pre-recorded. So everyone, if you can just follow, that'd be great. And don't forget, I do have this patient survey you guys can all fill out. Just go to either HerniaTalk.com or any of my social media. It's on my Instagram, it's posted. I have an implant survey, so please take that so we can learn more.
We've been posting it around.
Oh, I love it. Thank you.
We have been posting it around, so
perfect.
It's not going unnoticed.
On that note, I hope to see you again in person, Martin.
Yes, absolutely.
When you get your MRI, send it to me so I can read it for you.
Lovely.
And
we'll chat again.
We'll see you all next week. Thank you.
Lovely.
Thank you.
Thanks, guys. Bye, Dr. Tofai.
Bye, everyone.